Hello and welcome to the ASCO Guidelines Podcast series brought to you by the ASCO Podcast Network, a collection of 9 programs covering a range of educational and scientific content and offering enriching insight into the world of cancer care. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Rohan Garje from Miami Cancer Institute in Miami, Florida, lead author on Systemic Therapy Update on Lutetium-177-PSMA-617 for Metastatic Castration-Resistant Prostate Cancer, ASCO Rapid Recommendation. Thank you for being here, Dr. Garje.
Absolutely. Thank you so much for having me, Brittany.
Great. Then first, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO Conflict of Interest policy is followed for each guideline. The full conflict of interest information for this guideline panel is available online with the publication of the guideline in the Journal of Clinical Oncology. Dr. Garje, do you have any relevant disclosures that are directly related to this guideline topic?
Yes, I have received institutional research funding from Pfizer, Amgen, Endocyte, and AAA, who have drugs for the treatment of prostate cancer.
Excellent. Thank you for those disclosures. Then getting into the content of this guideline update, what prompted this rapid update to the ASCO guideline on systemic therapy in men with metastatic castration-resistant prostate cancer, which was previously published in 2014?
Since 2014, there are several new drugs that have been approved for prostate cancer management. And most recently, in March 2022, FDA has approved Lutetium-177-PSMA-617 for patients with PSMA scan positive metastatic castration-resistant prostate cancer. This led to the team from ASCO to develop this new rapid recommendation update. Now, this approval actually has been based on the efficacy data published in Vision clinical trial. To give you a little background about lutetium, it is a novel beta energy emitting radioligand therapy. In this particular study, this agent was combined with best standard of care and compared to best standard care alone in men with metastatic castration-resistant prostate cancer who had a positive PSMA scan. Briefly, the study was both clinically and statistically positive and has shown improvement in both overall survival and radiographic progression-free survival. The median overall survival was about 15.3 months with the combination therapy compared to 11.3 months with standard care arm.
Great. And then based off this new evidence and the new approval from the FDA for Lutetium-177-PSMA-617, what are the updated recommendations from the guideline panel?
The panel recommends the use of Lutetium-177-PSMA-617 as a treatment option in patients with PSMA PET-CT positive metastatic castration-resistant prostate cancer who have been previously treated with at least one line of androgen receptor pathway inhibitor and at least one line of prior taxane-based chemotherapy.
Great. And then what should clinicians know as they implement the use of this drug and this new recommendation by the guideline panel?
A very good question. It is important to select patients based on a positive PSMA scan. That is, all the metastatic lesions should be positive on the PSMA scan, and there should not be any large lymph nodes or visceral organ metastatic disease that are PSMA negative. Additionally, physicians can use gallium-68 PSMA-11 or F18 piflufolastat as radio tracers for PSMA scan to determine eligibility. Additionally, there are several other factors that need to be considered, such as the patient should have baseline good blood counts as well as renal function to be eligible for this therapy, as this treatment has the potential to cause myelosuppression and impairment of renal function. The most common side effects associated with this drug are fatigue, dry mouth, dry eyes, and nausea. The treatment in general is for 4 to 6 cycles. Each cycle is for every 6 weeks. The 5th and 6th cycle should be considered only if patients are responding well to the therapy and have no significant toxicities. It is also important for the physicians to note that there are several additional treatment options for patients with metastatic castration-resistant prostate cancer who had prior anti-androgen and docetaxel therapy. They include cabazitaxel, PARP inhibitors for patients who have mutations in DNA repair gene mutations such as BRCA1 and BRCA2, and immunotherapy with pembrolizumab for patients with MSI high status or tumor mutation burden greater than 10.
Thank you for describing that nuance behind the recommendations. So then, in addition, how does this update impact patients with metastatic castration-resistant prostate cancer?
Lutetium-177 PSMA is the first radioligand therapy approved for the treatment of prostate cancer. Previously, we had radium-223 as a radiopharmaceutical, but this particular agent is unique in the sense it is a radioligand therapy where it is chelated to PSMA. So it is very targeted therapy which works for both bone and visceral organ metastasis. So this is an exciting treatment option for patients as it has been shown to have improvement in overall survival. This adds to the current treatment choices of anti-androgens, chemotherapy, as well as targeted therapies for prostate cancer patients.
Great. It's exciting to have a new treatment option for patients. So then finally, what are the outstanding questions regarding systemic therapy for metastatic castration-resistant prostate cancer?
We are at an exciting stage in the management of prostate cancer. In the last decade, we have seen several new drugs. Some are specific targeted agents, some are specific immunotherapy agents. Now we are entering into this realm of radioligand therapy, which is very exciting. There are several other novel radioligand therapies such as actinium, thorium, lead, which are being evaluated in the treatment of prostate cancer. So the next several years, we will see several new drugs that are being developed. In addition, there are other agents called T-cell engaging therapies, which are being evaluated to improve the outcomes. So the last decade definitely has seen a lot of new improvements, but we are so excited that several new treatment choices are now available for patients and several are in clinical evaluation. So the future is bright for the patients with prostate cancer, where we have several new treatment choices to improve their outcomes.
It sounds like an exciting time for developments in prostate cancer. So I want to thank you so much for your time today, Dr. Garje, and thank you for all of the work you did to update this guideline.
Thank you so much. I really thank ASCO leadership and the team for giving me this opportunity. And thank you, Brittany, for hosting me on this podcast.
And thank you to all of our listeners for tuning into the ASCO Guidelines podcast series. To read the full guideline, go to www.asco.org/genitourinary-cancer-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, available in iTunes or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.